So, our agenda for today, I've asked our speakers to just hit the headlines first of all, so that we get a perspective of where global health or health for development is, and so that you understand where they're coming from. And then we'll move on to a more detailed presentation from each of them. And then, as I said, plenty of time for you to ask questions. We will have microphones. We've got to use those because of the roving mic, so please wait for one. Please tell us your name, affiliation, and who your question is for. And I will use the bell if the question is too long, okay? So please give everybody a chance to speak. If it's a detailed question about your own specific circumstances or a failed grant, please wait until you can have coffee and have a chat with people. It's the more general questions I'm sure everybody will want to hear. So I'd like to introduce the panel. Starting off with Trevor Manziel. He is President of the Global Health Programme from the Bill and Melinda Gates Foundation. We're very lucky that he was in the country, so thank you, Trevor. Chris Whitty from DFID, I'm sure everybody knows. Mark Palmer from MRC, and Jimmy Whitworth from Wellcome Trust. So thank you very much to all four of you for agreeing to do this today. So can I start off with our headline priorities and ask the panel, first of all, to talk about those headline priorities. And we'll start with Chris, if that's okay.
No, pass it on to Trevor.
Oh, okay, you've already swapped, okay. If you can pull the microphone across to you, please.
Great, Andre, thanks very much. Great pleasure to be here, actually, in the UK and sitting here with the three partners, the MRC, Wellcome Trust, and DFID, who are major funding partners in all of Europe, actually. And, you know, as much as we're very invested in global health, it does amaze me how much global health activity occurs here in the UK. We invest about $50 million a year in institutions here from the London School, Liverpool, Oxford, Imperial College, a number of your institutions, and also with individual investigators here in global health R&D, which is certainly far and away our biggest investment in Europe. So you've been a rich source of substrate for us. Just a few words about the organization. So I head up the global health part of the Gates Foundation. We had some reorganization earlier this year, and the global health component is really focused on research and development. And whenever I say that, people get very concerned because they say, well, isn't global health about actual delivery to communities who are desperate out there, not just about developing technologies? And that's absolutely true. But I define the endpoint of research and development as having some effective new intervention or even old intervention, which we actually launch into a community successfully. So we absolutely don't see the endpoint of research and development as something which is an interesting technology or product which people may or may not deploy. It is that element of actual deployment in the community. We have a substantial, very fortunate to have a substantial budget within the global health context to deploy on research and development, probably of the order of about $1.5 billion a year, which is a huge amount within the global health space. It's almost nothing within the healthcare space if you think that the aggregated investment by the pharmaceutical industry has now stabilized at about $130 billion a year in R&D. So it's very small in that context, but nevertheless, I think it's enough to seed some very exciting new opportunities we have to improve health in the poorest of countries. Our focus remains on the entities that you probably know well. We work in HIV/AIDS, from vaccines to male surgical circumcision across the board, malaria, tuberculosis, diarrheal diseases, pneumonia. We're in the last stages of our polio eradication campaign. By last stages, I mean a couple of years, but we have a clear plan for that to be successful. And then in maternal neonatal health and nutrition, so research and development across all those areas. That's all in my remit. I have a colleague, Chris Elias, who joined us fairly recently from the PATH organization, which probably many of you know. And Chris heads the Global Development Group. So he's much more focused on sustainable delivery mechanisms within countries, but also in other programs that some of you may intersect with in agriculture, water, sanitation, hygiene, financial services for the poor. So he really is involved in that. And my part is this R&D, but R&D with the twist that I mentioned. So I know I will get a chance to explain to you how we're thinking about our vast portfolio and how we think about organizing the R&D space. So I'm not going to get into that now, but pass on to Chris.
Thanks, Trevor. So in some ways, I mean, DFID works very closely with all of the other three organizations on the panel here. But in some ways, we're sort of a mirror image of the Gates Foundation in the sense that the great majority of what we do is delivery. And research is clearly a subcomponent of that, but it's not the primary end. Whereas in the Gates Foundation, it's really that it's the other way around. We both do a bit of both. And because it's a development agency, any research that's done in DFID, I have got to, or my colleagues have got to, stand in front of the minister with a straight face and say, you know, the opportunity cost for this is girls having education in Afghanistan, people having bed nets in northern Nigeria, improving governance in South Sudan. That, for us, is the thing it has to be able to be judged against. And for that reason, because it's development spend, what we end up very much concentrating on is things which we think will have an impact in the 5 to 10 year kind of time frame. We do have some investments in some wider technologies and things, including very considerable co-investments with the Gates Foundation, but our prioritization is towards the things we think will have a relatively near to medium-term impact. And alongside that, we recognize that there's a lot of extremely good basic science and good technological discovery being done by the other funders on this group and many others. And we've therefore tended to slightly bias our portfolio towards the more health systems end and delivery end of research, because there has to be a proper sweep. In terms of the priorities at the moment, I think most of them are the ones that you'd expect. Ministers, of course, come in with their own priorities, and they tend to be added on to what's already there at this point. DFID has been very fortunate that, because it's had a rising budget, as ministers have come in, we've been able to add incrementally the things which they're interested in, rather than have to cut away. That will stop very soon, actually, because our budget will stop rising in the next 2 years. Not till now. And the new priorities that have come in with this government, they made a very clear commitment on malaria, so there's been a significant investment in that, and in neglected tropical diseases. And there was a big, the London Declaration that happened this year was, I think, a major push on that. The Prime Minister has made an extremely clear commitment on hunger, so a lot of research around nutrition and also on the agricultural side, which, again, with the Gates Foundation, we have a very major program in, and ministers are extremely interested in issues around women's health. And additionally, we've got 2 new initiatives which we'll be doing jointly with MRC and Wellcome. We've already got one joint program which we'll talk about a bit later, which we think is very successful on clinical trials, and we're hoping to supplement that with a health systems research program, and we'll come on to why later, or some of the others will, and also one on humanitarian, because we accept that humanitarian health has been woefully under-researched for decades now. But I mean, there are a number of other things. I'm not going to list them all out. The one area we don't tend to concentrate on much is some of the middle-income country problems among the non-communicable diseases. We do some work in that area, but we try to prioritize only those things which we see as primarily a problem of the poor in those countries. So the fact there's a lot of obesity and diabetes in India, and India has got many poor people, doesn't mean that that is the primary problem of the poorest people. So where we do work in middle-income countries, it tends to be prioritizing those areas.
Thanks, Mark.
Thank you. So the Medical Research Council, of course, is mostly focused on research rather than development, but I'm pleased to say we've been able to work very closely with DFID over the last 20 years. We've had a concordat with DFID for that period, which enables us to actually bridge the gap between research and development. And by having this concordat, we're actually able to extend our own research agenda into the development agenda and support more of the research at the health systems and public health end of the spectrum. Of course, MRC's budget is split between an intramural program. We have our own institutes and units, as well as being a response mode grant program. And in the global health area, probably about 2/3 of the spend is intramural. The total budget per annum that we find allocated to global health is in the order of £50 million, and probably around two-thirds of that is intramural. And of course, the main focus is on our units in the Gambia and Uganda. And not surprisingly, those have to remain a key priority for us, not just because of the research that they do, but because of the opportunities they provide for the rest of the UK's research community to partner and to collaborate with those teams, and to ensure that there's a resource to do the research in country, in situ, as it were. So investing in those units, and there's been quite a review of the business plans for both the Gambia and Uganda in the last few years to make sure that they keep up to date and are still delivering high quality science. It has been a priority for us. Those units focus on infectious diseases, and most of our portfolio is infections focused. But in recent years, we have decided that we do need to move towards the chronic diseases. And MRC was one of the founding organizations in the new Global Alliance for Chronic Diseases. That is now, the Secretariat is hosted at UCL. And you're probably aware that the Global Alliance had its first call last year on hypertension. And we're hoping that in the next few months, the board will agree to move forward with a second call. I don't know exactly which area it's going to be in, but my money would be on diabetes. And that is going to be the basis, I think, in which we will probably see quite a bit of our investment in chronic diseases. Of course, for our grants are in response mode, and so very much the portfolio is driven by the research applications that we receive. And it is open to you to put in the applications that you want to see funded, obviously in competition. And those decisions are made by our research boards rather than having a specific tropical medicine or global health board. I want to just come back to the point that Chris made at the end about joint working with the other UK funders in particular, with the joint schemes that we've had in global health trials, and the scheme that we're working on health systems research. The questions that we're trying to address are huge problems, and they obviously far exceed the capabilities of any individual funder. And I think in the UK we've had the ability to work together quite closely. We've had a funders forum for health research in developing countries for the last 8 or 9 years. And we have, under the auspices of UKCDS, an ability to work together and to share best practice. And I think these new schemes that we've developed enable us to pool resources, to pool expertise, both from the technical and the managerial side of the proposals. And I hope that this is an area that we can develop in the future and build on for the strengths of the UK.
Thank you, Julie.
Thank you very much. So the Wellcome Trust is a charitable foundation which supports research with the aim of making extraordinary improvements in human and animal health. Our focus is particularly on people. We like to identify bright, driven individuals who we're then able to fund and support as long as they are productive. About 15% of our funding is allocated to work in international, for global health, and we have 3 main themes for our global health programs. One is in broadening the research base upon which knowledge can be generated in low and middle income countries. Put simply, that's capacity building. The second is around supporting research which we think has the promise of improving human and animal health. And of course, in low resource settings, the opportunity to do that is much more acute and much more obvious what can be achieved. And the third theme is around developing and supporting networks and partnerships on issues of relevance to problems of low and middle income countries. The recognition that none of us can do all this by ourselves, and there's much to be gained from working together and collaboratively, as you've heard already from the other speakers. We fund a very wide range of different types of research. In science funding, this would go from basic biomedical research through to public health research. We also fund some of the softer sciences, society and health, in ethics, public engagement, and history of medicine. And also we have a technology transfer division which is interested in delivering products and devices to the market. And much of that work is actually focused on problems in low and middle income countries. All of the funding that we provide is underpinned by a merit-based, peer-reviewed, and we hope transparent process for identifying the very best grants.